So welcome everyone to day 2 of the McMaster Midwifery Research Center 2024 Midwifery Research Symposium. Thank you so much for joining us today. We're grateful to have you here. Hamilton is where I am today. I'm on campus at McMaster, and this land is situated on the traditional territory, which has long been a meeting place and home to the Haudenosaunee and Anishinaabe First Nations. Their presence is foundational to the history and culture of this land and is recognized in the agreements of the Dish with One Spoon Wampum Belt and the Haldimand Treaty Territory. As a settler, we must acknowledge that our role is as guests on this land and that we share in the responsibility of its caretakers to ensure the sustenance and well-being of all. We commit to honoring the spirit of these agreements by striving to never leave the dish empty and to share what's in the spoon or the resources of this land equitably, and to engage in meaningful efforts to restore relationships with the First Nations and Indigenous peoples of Canada, built on principles of peace, friendship, and trust. And I personally am committed to actively learning and unlearning and listening to the narratives that have shaped the understanding of Canada and its peoples. And this is a crucial step towards truth and reconciliation and the ongoing process of decolonization. So thank you once again for joining us today. This symposium is an annual event where we showcase important topics in midwifery here in Canada and globally. And we have different presenters and topics each day. So please take a moment to look at our program and schedule, and all of the details about the event are on our website, which is mmrc.mcmaster.ca. So lots of great resources over there, including bios, and that's also the home where we will post the links to recordings after the symposium is done. So feel free to head back over there afterwards, and it give us a little bit of time to get those recordings up and ready to go. But you can even now go and check out previous year's symposiums. We were just talking before we started that I think this is our 8th symposium, and we've been online for the last few, and it seems to work really nicely to have people join us from wherever they are, and to be able to kind of learn a little bit and share in a conversation in a way that works for them. So thank you for joining us. On the international stage, I think it's known by many people in the midwifery field that there's been lots of work exploring sustainability of midwifery and looking at the evidence related to continuity of care. And we're really hoping that we can dive into that conversation a little bit more today by sharing perspectives about continuity of care from around the globe. And we're really lucky to have panelists from the Netherlands, from Indonesia, from Ethiopia, and from Canada. I will be the moderator for the discussion, and our panelists have some dedicated questions that they're going to answer. We'll take 2 rounds of questions for each speaker, and then we will have time after that to open up to questions from the audience. When we get to that portion of the panel discussion, you can put your questions in the Q&A box, or you can raise your hand and we can turn on your mic for you and allow you to share a question verbally if that's something you'd like to do. I would encourage you to go to our website now, too, if you have a second browser open, where you can check out the bios for our speakers today. I'm not going to be reading their full bios, but there's lots to share there and to learn about our speakers. So if you have a chance, head over there and check that out. But to begin, instead of reading the formal bios, what I thought I would do is start by having people introduce themselves and share just a brief intro about who you are and what you do. So I'm going to go in the order that you are on my screen. So Renata, I will have you go first.
Yes, thank you so much for having me. I'm a midwife, currently working in a big hospital in Amsterdam, and I'm also a PhD student, and the topic of my research is the implementation of continuity of care.
Lovely, thank you. Okay, Solomon.
Okay, thank you so much. I am Solomon from Ethiopia. I've done my PhD in midwifery and medicines with a dissertation title on effect of midwifery continuity of care model on maternal and neonatal outcome, as well as utilizations of maternal care. And we, of course, we also measure the satisfaction level of pregnant mothers after having midwifery continuity of care model. and currently I'm working at a university as a midwifery assistant professor in midwifery and women's health. Yeah, thank you so much for inviting me to this very important webinar on midwifery continuity of care model.
Thank you. That's lovely. Yes, we saw some of your papers and we were really interested to hear more about that research that you've been doing. So I look forward to hearing more about that. Next, Disa.
Yeah, thank you so much. I was looking for the button to unmute. Okay, so good afternoon from Hamilton. So I'm a midwife from from Indonesia, as you can see, but at the moment in Canada, and very nice to have a project together with McMaster. And I've been qualified as a midwife since 2007, and currently working at the Midwifery Study Programme, Universitas Airlangga. And I've been involved in a couple national projects under the liaison of associations of Indonesian midwifery education. So it's working closely, pretty much closely with the government, setting up various standards of midwifery education in our country. So yeah, very lovely to see you all today.
Great, thank you, Disa. And Megan.
Hi everyone, my name's Megan. I'm a midwife here in London, Ontario, in Canada. And I work with Beth Murray-Davis and the McMaster and London research team. We're currently working on a study exploring the perspectives of clients when it comes to continuity of care. So I'm very happy to be here, especially in light of some bigger conversations happening within the midwifery profession here in Ontario around how we can, keep midwives in the profession in light of some sort of, resource strains and burnout, as I'm sure we're all feeling, but also just being able to protect continuity as well while we're sort of planning for how to scale midwifery more and more.
Thank you, Megan. Okay. So maybe we'll stop sharing our slides. Thank you, Rash. It's like we're on a mind meld. And what I'd like to do is move into kind of our questions for our panelists. So we're going to do a first round of questions, and each person is going to tell us a little bit about what continuity looks like in their country, and then I have some specific questions. So we're going to begin with Disa. So can you tell us about the model of midwifery care in Indonesia for people who might not know what the model looks like? And also tell us about the potential that you see for creating continuity-led continuity models of care and what you think the challenges will be for implementing those in Indonesia.
Yeah, okay. So thank you, Beth. So talking about the model of midwifery care in Indonesia will depend on the setting where they work. So basically we have three main settings, including primary health care, and then the secondary, and then the tertiary. They all have midwives, and but the kind of care provided might be different. And generally, the scope of practice of midwives is stretching from the preconception until menopause, or even the climacterium stage. So basically, we are always with women during their life cycles. And if I'm not mistaken, according to Indonesian health minister's regulation, in 2021, comprehensive health services were set to reduce the maternal and newborn morbidity and also mortality rates, because what we have at the moment is really high. It's around 170 per 10,000 births. So yeah, so they set up the pre-pregnancy services, everything to produce that cases. So the pre-pregnancy services meant to give the care to prepare the women for the healthy pregnancies throughout the through the educations, and then giving the appropriate counseling and then the health screening, etc. And then the pregnancy services, including at least 6 antenatal checks throughout the antenatal period. And then it will be focusing on measurements and then immunizations and then maternal and fetal health assessment as well, and then the childbirth and the postpartum care. So well, we do the contraception care as well, and with the some certain or it could be additional can I say additional it's just like a certifications or additionals top-up skills. Yeah, so this all the regulations actually to ensure the comprehensive care for the women and also the infants throughout the reproductive journey. However, if we are talking about the continuity of care, I think the degree of the continuity might still be a problem in our country. Pretty much like mostly women just come to wherever the setting they need, and then mostly will come to the primary care if the case is just straightforward. I mean, with no problem at all. But if there is something happened, they will be referred to the higher settings. But that is the thing, because with such existing model, normally there is no continuity in terms of communication and management of the case overall. And then I think that will be a little bit difficult to track the history of the women or patients. So it is more like the way we see the continuity of care is a little bit different. So in our country, as long as the women see the care provider, whoever it is, it will be considered as a continuity of care. So which I believe that would be hard, for us to categorize as the continuity. And I think it could be potential, because nowadays in our settings, and I think more growing, people tend to have a more a more sophisticated care that is provided by the doula and also the midwives. We don't really have the doula in our country, but some they call themselves as a doula, just simply because they're with the mother during the birth and providing the care and just providing and being with them is just to calming, help them to coping the pain or etc. And people see that this is an additional care. There is actually there's the primary care. It should be provided by the midwife, but unfortunately, as our practice have been many years only regarding to the standard operational procedure set up by the government. So we tend to provide the care is more like a medicalized care and just by an order. As long as I do this based on what the government says, that will be safe, and that's it. So we don't really get the woman involved during the care, which this can be this have been seen by the doula as an opportunity to give them more. And the fact that the woman willingly to pay more, because normally the women or the patient can be covered by the national health insurance, I mean, provided by the government. But if you want to have an additional care, like what I said, they need to pay by themselves. So yeah, I think yeah, it's a little bit tricky in our country, but we do have a continuity of care. But if we're talking about the degree of continuity of care, it will be depend on where the work and where the setting is. And as I mentioned that we have three settings basically. On the secondary or the tertiary health settings, they don't necessarily know the patient or the women during the antenatal period, because what we have in our system is we call it a referral system that is specifically setting up the standard and the norms where can you get the care and how you're going to be with. So if the birth and the antenatal is just, the case is just straightforward, I'll just go to the primary, but then in a specific area based on when you based on where you registered. So yeah, it's a little bit challenging, because once there's a problem with the pregnancy or during the intrapartum, we should be brief, and the women should be referred to the secondary or tertiary. They don't necessarily know the midwives or the provider who are going with them. So which I think is that will be a little bit hard for from the perspective of the women, as they what we believe that women as the center of the care, but in this setting, yeah, that we just follow the procedure, and we don't really what can I say? We do care, but we don't really give them space to express what they're feeling and what they're concerned or etc. So yeah, that's the kind of model what we have in Indonesia, and what I can see as the potential, because there is still space if we are. But I think this should be we need to look it a little bit more deeper, maybe through the research or even the publication, to amplify the fact that I'm sure that most of the women, if they are if they're seeing the same midwives during the antenatal and intrapartum and also the postnatal, at least, I think the satisfaction is I think the satisfaction will be better, because not only based on the evidence on the systematic review that lately published by the Cochrane, but also in the real setting, I'm sure that this been our concern, because I think most of the time the women's confidence not really been the main focus of our care. So talking about the empowerment and also how to empower them to believe in themselves, we need such a trust, and trust should be built by the one we know. So yeah, I think there is still a potential space to build the continuity of care, which I'm sure there's going to be a lot of work, but I'm still optimistic, and we're still optimistic, as long as yeah, because we have that wide scope of practice, stretching from the prenatal until the menopause. That could be opportunity as well. So just to preparing the system, there is we need to get it settled and talk to the government to help us with the such system. I think that's for the first path.
That's great. Thank you so much, Diza. You brought up so many key points already, I think. Looking for, how to reduce mortality and morbidity and have that be a real driver in your country.
Yes, that's the
it's a huge issue, right? And I think
main issue.
As you said, the scope of care is so broad as well, and that's a challenge for sure. And the referral system, the way that it's set up and how a patient might move through that referral system. So you've touched on a lot of those kind of challenges and barriers. But it sounds like there's lots of opportunity there, as you mentioned, to create, more informational continuity and build those relationships of trust. So I think we'll have a chance to keep unpacking some of these concepts that you've raised. So thanks so much for getting us started.
All right. Thank you, Beth.
Next we're going to go to Renate. So can you tell us a little bit about midwifery-led continuity of care models in the Netherlands? And why don't you also share with us a little bit about what you've learned, maybe in your PhD research, around implementation of continuity models in the Netherlands?
Yes, thank you, Beth. A bit similar, like Indonesia, we have a referral system. The Dutch maternity care system is based on a division between primary care provided in community and secondary and tertiary care in the hospitals. And the care the women is receiving is based on the assessment of the individual risk. So women with a low risk pregnancy are cared for by community midwife in midwife-led primary care. And women at intermediate or high risk are referred to obstetrician-led secondary or tertiary care. Where they are looked after by also hospital midwives, nurses and obstetricians. And this separation can sometimes lead to challenges in communication, coordination between midwives and obstetricians, particularly in cases requiring referral or transfer of care. And in many regions, there is a lack of integration of community-based midwifery care and hospital-based care, which can result in fragmented care pathways, particularly for pregnant women who require transfer during pregnancy or birth. And policy states that each full-time community midwife manages 106.6 full courses of care annually, and it differs per practice if this amount is achieved. There are many practice forms and sizes. There's no maximum number of midwives that provide care for pregnant women that one woman gets to meet. So there are caseload practices, but also practices with 12 midwives and everything in between. Although research has shown that the chance of referral to hospital care is greater in large practices, so the chance of referral reduces with a small practice. But the structure of maternity care, both financially and organizationally, acts as a barrier in the implementation of continuity of care. Because providing continuity of care results in reduced financial income for the midwives, and has a direct impact on their personal lives, with more on-call duties. And how community midwives manage these barriers depend on their personal interests, their vision, their personal life, if they can combine it. Midwives who are willing to implement continuity of care are faced with an inner conflict. It's like an ethical issue. What's the best care worth? And we see that midwives who start caseload practices often discontinue after a few years, because of the unsustainable nature of the workload. Yeah, it's difficult to implement. The midwives are willing to implement, but they face so many barriers on the way to get there. So in my research, I take a realist approach. So I'm looking at which mechanisms occur in what circumstances, in what context. So I'm looking into how and in what circumstances continuity of care can be implemented and how.
That's fascinating. Yeah, it's interesting to hear the combination between the referral systems and the impact that that has on continuity. And I think you've raised some great points around, you know, those transfers of care and how people end up with very fragmented care. And yeah, I'm really fascinated as well by that question about what is the best care worth. If we all know that continuity is associated with, you know, the best outcomes for the pregnant person and the newborn, you know, how much is that worth to the midwives, to the healthcare system, to policymakers? How do we build a system that actually supports that and is sustainable for the people who are doing it? So yeah, very interesting. Where are you at in your PhD research process? Are you finding out some interesting insights?
Yeah, definitely. Like, for example, the financial system, as I explained, that acts as a barrier. But what you see is that like a C-section, for example, or a complicated vaginal delivery, it leads to more profit for an organization compared to an uncomplicated birth. So like a birth center, it doesn't gain as much money as specialized care. So that's for organizations, for hospitals, it's
there's motivation.
Yeah, it's a barrier.
Yeah, so interesting.
Yeah, exactly.
And so it's interesting because your research also sounds, we don't have a panelist from Australia. It's always challenging to have them join because of time zone differences. But I know there's been research in Australia that looks at the implementation and organization of continuity models. And they found, you know, that midwives like it, right? That it leads to job satisfaction and to, you know, feeling more joy and reward in your work. But you raised the issue that for the midwives in the Netherlands, they end up making less money and feeling more demands on their time by offering continuity models. Can you expand on that a little bit?
Yes, so with my research, as I explained, I'm looking at context and certain mechanisms that occur in these contexts. And I'm also looking into why for some midwives it protects for signs of burnout, while for others it increases the chance of a burnout. So it's all dependent on the life cycle where one's at. So does a midwife have small children, for example, or care for other people? Then that can be a barrier because there are a lot of obligations on her shoulders, and it's difficult to manage that, combine that with all the on-call duties.
Right.
Which is very unpredictable, of course.
Right. Yeah. Interesting to bring that up, the midwife, where they are in their life cycle. And last year we had a panel on sustainability of midwifery, and Billy Hunter from the UK said that they found the same thing, and they went and asked specifically the people who were staying in continuity models and, you know, staying in the job of a midwife, what kept them there. And so there's a lot that can be learned when we compare people who leave and people who stay and why they stay. So wow, lots of rich data coming out of your PhD. That's fantastic. Thank you.
Hope so, yes.
Okay, well, why don't we pause there and switch to another panelist, and then we'll come back around in the next round. But I'd love to hear from Solomon. So it sounds we've had a good kind of snapshot of midwifery and implementing models of continuity in a couple of countries. But can you tell us about how midwifery-led continuity of care has been implemented in Ethiopia, and then what your research has found about the impact of that model on clinical outcomes?
Okay, yeah, thank you so much. As the previous panelist explained, in Ethiopia, the experience is almost the same. Before I implement the midwifery continuity of care model, it was not actually practiced and implemented in Ethiopia. What we have in Ethiopia is, we call it the shared model of care. When we say the shared model of care, where every healthcare provider, be it a midwife, a nurse, or a medical doctor or obstetrician who work in the maternal and child care unit, would have the right and the responsibility to provide the care. So in this case, we call it the shared model of care. But in the context of midwifery continuity of care model, the midwife is the lead healthcare provider who makes a decision and who provides the care, starting from the antenatal care up to the postnatal care period. So in Ethiopia, it was not implemented. So what we did is, after we developed the proposal and the whole proposal project, then we select 4 primary hospitals. In Ethiopia, we follow a 3-tier healthcare system: primary healthcare, secondary, and tertiary or referral healthcare system. So in all the 3 healthcare tier system, midwives are really deployed and work and provide care. So previously, the midwife might be provide antenatal care, they may provide intrapartum care, and they may provide the postnatal care. They also provide family planning and other gynecology cares, including abortion and other gynecology cares. But what we have is, when midwives are working the antenatal care, they only provide the antenatal care. They may not provide the intrapartum care. When the mother goes to the intrapartum care, she may get another new midwife or new nurse or new healthcare provider who doesn't meet her during the times of the antenatal care. You see, so literally there is a discontinuity of care. Even though the mother receives the antenatal care, the intrapartum and the postnatal care in the same health facility, but along her journey, she might face or she might get a different healthcare providers in each and every visit. So with this context, we can consider that there is the woman might receive antenatal care, intrapartum, and postnatal care in the same facility, but she might get a different healthcare provider. So with this context, we can say that there is discontinuity of care. So what we did is, we select 4 primary hospitals. Then we consider 2 of the primary hospitals as intervention hospital and 2 of the primary hospitals as control hospital. So for the intervention hospital, we recruit midwives and we provide training, an intensive training for midwives about the philosophy and how they organize themselves and how they will provide continuity of care from antenatal care up to the postnatal period. Then after that, after we train the midwife, in the context of continuity of care model, we do have 2 types of continuity of care model: the caseload and the team-based midwifery model of care. So for this reason, we select a team-based midwifery model of care. So literature shows that in a team-based midwifery model of care, we can organize a group of midwives, a small group of midwives, 4 up to 6 midwives. Then they will provide around 360 pregnant mothers annually, starting from antenatal care up to the postnatal care. So we select midwives and we group them into a small group, 4 to 6. Then we provide training and we train them about the philosophy of continuity of care model. Then we provide them a count number of pregnant mothers, and we leave the control hospitals as it is. So we totally select 1,178 pregnant mothers, low risk pregnant mothers with gestational age less than 20 weeks of gestational age. Then we recruit for the intervention control hospitals. Then we start collecting a baseline data starting from the antenatal care. Then we just follow up to the end of the postnatal period. Then finally, we measured the maternal outcome, neonatal outcome, maternal health care utilization, and maternal levels of satisfaction. And of course, before we conduct this, we also do a qualitative study, a qualitative exploration about the midwifery continuity of care models, including the policymakers, hospital managers, and even midwives, how they feel, and do they have any previous experience about this. So after that, we collect the data and we measured. What we found is we really impressed with the finding. It really improves both the maternal and neonatal outcomes. It really improves the rate of spontaneous vaginal delivery, and it hugely reduces the rate of unnecessary cesarean sections or unnecessary medical interventions. Because from the very beginning, the underpinning philosophy of midwifery continuity of care model is it promotes normalization rather than providing unnecessary medical interventions. So when we see the Ethiopian context, having unnecessary cesarean section or unnecessary medicalizations of obstetrics care becomes more common in urban areas where obstetricians are really available and where these medicalizations are accessible. But when you go to the rural parts of the country, it may not be available. It may not be done. Why? Because it is not accessible. The emergency cesarean delivery or the emergency obstetric service may not be accessible for pregnant mothers. So they may not be. But it becomes a very risky and dangerous experience for our country, for those pregnant mothers who really live in the big towns like Addis Ababa and other capital cities of the regional states. So it reduces unnecessary cesarean sections. It reduces the rate of instrumental delivery, especially vacuum delivery, and for forceps deliveries are really reduced. It also reduces rate of preterm births. Admission to neonatal intensive care unit was hugely reduced, and 5-minute Apgar scores of the neonate, especially after 5 minutes, and was really improved. Why this happen? Because this happens because the woman receives the same healthcare provided from antenatal care up to the postnatal care. And when we measure their level of satisfaction, they really satisfied with this care because they build a trustworthy relationship between the provider and the woman. And they really trust on that, and they really feel free to ask questions and to receive the quality care because the care was provided by the same midwives starting from antenatal care up to the postnatal care. So we really found a very promising results. So what remains is we wanted to scale up this because this is the only evidence we have in our country. Of course, in lower and middle income countries, especially in the sub-Saharan African countries. And of course, it was also recommended by WHO as a context recommendation. So we report our finding to the Ministry of Health in our country, and the Ministry of Health starts to develop a guideline how to implement midwifery continuity of care model in our country. You see? So what I advise other individuals who want to implement or test midwifery continuity of care model is, one, they need to contextualize which one is more better and appropriate for that country. Is that the Kidwood or the team-based midwifery model of care? Because along our study, we found a very important challenge. The most important challenge is the workload, because we have only 22,000 midwives for 120 million population. You see, so midwife to population ratio is really below the WHO standard. So with this number of midwives, scaling up a midwifery continuity of care model to the larger scale may not be appropriate. So from the very beginning, we need to think that is the health facility have adequate number of midwives to population ratio. That is the most important thing. Because if they feel that it is a workload and burnout, they may not implement midwifery continuity of care model. You see, because it really demands their time. Because when a pregnant mother has any complication, they may call and come during the night or during the weekend or during their free time. You see, so these kinds of things may burn out and may increase work-related burnout for midwives. That is the most important thing. So we need to be sure that we do have adequate number of midwives per population ratio. That's the most important thing. The second one, there has to be a very supportive policy legislations, rule and regulations has to be there. So we implement midwifery continuity of care model. Why we implement? Because it is a PhD study. So if we wanted to continue this thing, there has to be a very conducive working environment. So to have a conducive working environment, there has to be a supportive policy, legislations, guidelines has to be there. Unless the midwife, if they want to, even though the midwife wants to implement midwifery continuity of care model, they may not implement that one because the policy, the guideline may not support them, you see? So that is another very important challenge we identified. So there has to be a very conducive working environment. The other thing, training and capacity building is another very important issue because midwifery continuity of care model is a new concept. So the graduating midwives may not know, may not have adequate knowledge and skill on how to implement continuity of care model. So the concept of continuity of care model has to be included in the curriculum, and those who work in the health facility needs to train and needs to be what? Capacitated. Unless and otherwise, they may not implement that one. So capacity building, training, or a continuous professional development has to be there to implement successfully midwifery continuity of care model. Otherwise, the midwives are really very interested to implement this. Why they are really interested? Because it provides them autonomy, professional autonomy. It also allows them to practice the full scope of what? Their profession, because they will provide the care from antenatal care up to the postnatal care. So they will provide end to end. So it gives them power. It gives power for midwives to implement the full scope of their profession, professional autonomy, decision making, and even visibility of midwives will be improved. And a trustworthy relationship will be created between the midwife and the healthcare provider, or between the midwife and the pregnant mother. So it really satisfies both the midwives and the mothers. Yeah.
That's amazing. That's been so interesting to hear about that experience. And it's, I really commend you as well on being able to implement it from the beginning and to be able to compare models, traditional model, and then the intervention of continuity. Because I think that's such a powerful way to then really let your outcome data speak for itself, that continuity is an important intervention that can improve outcomes. And yeah, I think you've also highlighted a lot of key points around the importance of workload, the importance of those supportive policies, embedding continuity into the curriculum for midwifery learners. So lots we can really think about and reflect on there. I'm going to shift to our last panelist, and then I think we'll come back to a lot of these themes in our second round. And we will hold questions until the panelists are done. And if you want to type a question in the Q&A box, you could put it there and we will come to it when we have our opportunity to take questions from the audience. So down at the bottom of your Zoom panel, you'll see a Q&A box. You can go ahead and type your thoughts there. And we've also put a link to that Cochrane review that was recently published about continuity and some of Solomon's work in the chat. But Megan, we are interested to hear from you about midwifery-led continuity models in Canada, and then also what you can share with us about the service user perspective and experience related to continuity.
Yeah, thanks. So it's so interesting to hear everyone talk about so many of the same issues that we have here in Canada. So in Canada, midwifery, so I'm sure in most countries, midwifery was very much pushed out, over the past century. And so it's been a hard fought battle to try to reintegrate into the healthcare system. So I'm in Ontario, but historically, continuity of care, it's really always been part of the model of midwifery care in Canada. It's one of the sort of historically required tenets of midwifery care. Now, in the last sort of 30 years, the definition of continuity of care, or its mandate and what it looks like, has shapeshifted a little bit, partly because of the issues that many of you are bringing up around capacity and midwives not always being able to do caseload midwifery and being able to work in the same caseload model that the profession was historically designed to do. So in some parts of the country, continuity, really the definition has now changed to a small group of midwives who are share the same philosophy of care, who build a relationship of trust with their clients. So it's vague, but also specific enough that the expectation is that really we're building trust with the client over the course of their prenatal, intrapartum, and postpartum care. Now, in the last sort of 5 to 10 years, this traditional model of, having somewhere between 2 midwives on a team, anywhere up till sort of 8 to 12 midwives on a team, has changed to allow for more and other healthcare providers to come in and be a part of that team as well. So traditionally in Canada, midwives were really responsible for low risk pregnancies. So we were really designed to sort of meet the needs of the low risk population, but that population has been changing over the past sort of 20 years. And now we're finding through some of even the Canadian data that midwives are taking care of clients who have higher, more complicated pregnancies, and with good outcomes as well. So historically it was very low risk, but now we've gotten really creative, partly because we want to meet the demands of the clients and what they need, but also the midwives are really looking for other ways to be able to work in their scope that doesn't involve as much on-call time as historically we've been doing. So some things that have come up, which is really cool, is in Ontario, we have these expanded midwifery care models, so EMCMs. So these are unique models that the government funds to help midwives either focus their clinical skills or their area of expertise. Sometimes these clinics are for specific parts of pregnancy or specific populations of people who may have higher needs or more complicated needs that deserve a specific focus. And then other options are just interdisciplinary clinics. We have some really interesting clinics coming up that involve potentially obstetricians, other midwives, as well as nurse practitioners, pediatricians, family physicians. So midwives are really, really creative and have come up with really unique ways to meet the demands of the clients, but also try to stay in the profession so that they aren't leaving. And in Ontario, we've had a number of midwives leave the profession, especially after the COVID-19 pandemic, because in the pandemic, I think we were really all focused on, sort of fighting against one thing, which was the pandemic. So we united to get through that piece of it. And then after that sort of started to sort of dissipate, midwives, I feel, are really sort of post-pandemic struggling to sort of keep in the game. So we're seeing more stress and burnout after that. What's interesting about what everyone is talking about here is that it really does come back to the bottleneck of the midwife. So continuity, we know, is associated with more positive health outcomes for the birthing parent, the mother, and the baby and the family. But what's interesting is really, I think the best way to keep continuity of care in some capacity is to protect the midwives as much as possible, which is, Solomon, partly what you're talking about, is scaling the profession so that we're able to keep midwives in the game. And so from the client perspective, I think the clients, we know through informational, relational, and management continuity, the clients really benefit from continuity. And I think one of the biggest issues I've seen in the post-pandemic with the resource crisis, we've had fewer midwives in Canada around, which has compromised continuity, because when you lose midwives, the team is fractured and the caseload then gets shuffled, and then clients are needing more midwives. And so it becomes this chasing continuity game, which is really unfortunate. But yeah, what we're seeing is this sort of really need to figure out how to protect keeping midwives in the profession so that we can keep continuity. And everything you said, Solomon, and Renate, about really meeting midwives where they are and what they need is a huge focus here. Part of the work in Ontario right now around protecting the profession is identifying these key areas. The work done by Dr. Christina Madison with the Association of Ontario Midwives, really talking about these key points in the midwife's profession that pose a bigger risk for leaving the profession. And so why this is so important is because when we leave the profession, continuity is very much a problem. So we really do feel continuity is very, very important. With our work, with Dr. Murray Davis, with Beth, we're looking at the client's perspective. And so unfortunately, we're in the middle of data collection right now, so we don't have those findings to share with you. But what we're trying to figure out is what is the secret sauce around, you know, that secret sauce of what clients need in their care, and how do we keep that in the face of health human resource crisis, at least in Canada and Ontario, around how do we keep the profession, how do we scale it, but also keep these really great positive health outcomes that we see with continuity, but in a way that intersects with midwives being able to stay in the profession in a way that works. So we're going to be asking questions about, you know, how many midwives, was that the most important piece? What were the aspects of care that were the most valuable to the clients? Because when we see more relational, informational, and management continuity, we see higher satisfaction. So our question really is around how do we keep those pieces, but also in a way that allows midwives a bit more flexibility to be able to work in different capacities across that lifespan, as we mentioned, because sometimes we do have little children, sometimes we have aging parents, or we have a disability ourselves that prevents us from being able to work in an intrapartum capacity or the on-call world. So yeah, I think midwifery in Ontario, continuity is a big piece of what we're really wanting to preserve, but we're coming up with really new ways to be able to even honor some of what Solomon, you said, the prenatal sort of piece, and then the postpartum piece, and then maybe intrapartum is maybe done by another midwife, but in a way that protects that relationship a little bit.
Thank you, Megan. That's a good insight into how things are working and some of the current challenges that are happening in Ontario. So what I want to do now, I think it's been really helpful for us to hear from each of the panelists about what continuity models of care might look like where you are. And you've all touched on some of the challenges that have been encountered in your own settings, but maybe we could talk a little bit, and we can go in the same order that we went in before, about what you think or what might midwives in your country learn from what you've heard here today about some of the examples of continuity in other countries. And, you know, what do you think? I think most of you touched on challenges, but if now you have some new thoughts on challenges that you're facing related to continuity, you can share that. But we'll keep these responses maybe just to kind of 2 minutes each so that we can then transition into audience questions. So Disa, do you want to tell us what you think midwives, what you
Yes.
learned?
Thank you. So I have highlighted a couple of things from what Solomon said, and also it's very nice to hear from Brenna and also Megan. I think we need to get settled. Very first thing is regulation, because in our regulation, it's not necessarily setting up the quality of the care. They more like a quantity minded, as long as the women fulfilled 6 times during the antenatal period, regardless whatever the quality is, just okay, it's enough, and you've been seen by the provider, you'll be healthy. And then and the second is, I agree that the philosophy of care should be the very first thing. We need to make sure that the midwife, all the midwives in the team have the same understanding. And it's been our concern as well, because as in Indonesia, for many years, we were working under the medicalization system. And even the midwifery education in the previous, well, I can say maybe 2 decades ago, we were all trained by doctors and pretty much having the same philosophy as a doctor. So there's no necessarily difference between what we're doing and what the doctor do, unless it's the ultrasound, which is, yeah, because we've got different philosophy, should be different how we provide the care. and trying to find the way. I mean, by hoping that the government will support us with the system. What Solomon has explained is really important, because now what we have is really fragmented. So we do have that level of care, the primary, tertiary, and secondary and tertiary, but not necessarily we connected one to each other. And then I think to build the capacity of the midwives as the professional leaders should be one other thing that we should work on, because we are not used to it for many years. That yeah, we're just working under the doctor supervisions. So yeah, I'll just do what the doctor said. And also the sharing the responsibility in our settings, currently the issues. So if I go to the private practice midwife, then midwife will responsible to my care. And then when the women go to women go to the hospital, whoever in charge, the time will be responsible to their care. But all the care providers that women have seen, not necessarily connected one to each other. So I think, yeah, I've got a couple of things that, yeah, I learned from your system, Megan. It's really good to see that you have a new model as well. And yeah, maybe very first thing that we should work is building the capacity of the midwives, because I think if we are strong enough as a midwives to we can then advocate the government through the research, to the data we're collecting, because we have the same vision, we have the same philosophy that we really want through this continuity. I think that's from my view.
Thank you, Tisa. Yes, and I think you and Solomon should talk after, because I know you're interested in how you train midwives to work in continuity models, and it looks like that's a big part of what was part of the intervention that Solomon was speaking about. And I think, yeah, I think the challenges of that fragmented care, and what I'm learning about Indonesia, and it sounds like Ethiopia may be the same, and Canada faces the same challenges related to sometimes geography and the rural and remote locations, and how continuity may not be evenly available, accessible, or equitably rolled out in different locations across our countries as well, which is a challenge. So yeah, there's lots of good learnings that we can share with each other. Okay, Renata, what are your thoughts on kind of what midwives might learn about continuity from some of this conversation today that you think you could take back to the Netherlands, and what you think some of the challenges are in your setting?
Yes, I agree that we need a shared philosophy, not only among midwives, but also a shared philosophy with obstetricians, because we work closely together. And in the Netherlands, there's a lot of tension between the two professions, with each group seeking to protect and extend their jurisdiction. And it's not, at this moment, it's not really collaboration, but more competition. So that moved the conversation away from what must be done to deliver the best and the most effective maternity care, to efforts to promote the value of the services of one profession over the other. And also using research in that direction, instead of working together to identify the most effective ways to deliver care, like continuity of care. Showing the benefits of each profession. And midwives have less political power and access to policymakers in the government and insurance industry, compared to obstetricians. So the obstetricians are succeeding in increasing their role in maternity care. So they have a lot of power. That what makes that midwives are unable to implement continuity of midwifery care.
Yes, that's a great point. I think you're right around the competition piece, right? And how the differing philosophies continues to be a challenge, and the marginalization of midwives into, you know, this is your sphere and the rest belongs to physicians, continues to be a challenge. Yeah, and I think Megan, you spoke about collaboration and how that is a key part of how we can ensure continuity, but that, you know, that successful collaboration is a real challenge sometimes when there's that competition for finances and power. Yeah, so really interesting to bring that up. Solomon, what do you think are some lessons about continuity that might fit in your setting, and what are some more of the challenges that you see again in your setting?
Yeah, thank you so much. Yeah, first I will see this concept into two. The first one, with regard to the positive impact of continuity of care model in high-income country, I believe that there is a lot of evidence. We can say that there is enough evidence is generated in high-income countries, so it may not be a problem. But when it comes to lower and middle-income countries, still we need to generate more evidence how it works and how we're going to contextualize with each countries. So what midwives should learn from this is they need to work and generate more evidence, country and context-specific evidence on continuity of care model, how it can be done in their country, how it can be scaled up, and what will be its effect on maternal, neonatal outcomes, and other maternal and child health issues. So the first thing is that is we need to learn from that, because the context is different from country to country. The number of midwives, the number of case loaders, the structure of the facility, their policy, and other issues are really different. Besides, generally, we believe that continuity of care model has a positive impact on improving maternal and neonatal outcomes. So that is the most important thing we need to learn. So we need more evidence, which is country specific and especially lower income countries. The other thing, midwives should believe on this model of care. First, we need to believe on that as a midwife. So we need to work on that, and we need to influence policymakers or even healthcare facility leaders or managers in their small circle, in their health facility from the very beginning. So they need to prepare themselves, they need to capacitate themselves, and they need to organize themselves and start to work in continuity of care model. So, you know, implementing continuity of care model really doesn't require any sophisticated technology or requirement or infrastructure. Rather, it needs the commitment from midwives and reorganizing themselves. That is the most important. Otherwise, the antenatal care, the intrapartum care, and the postnatal care is similar. It doesn't differ from, be it in a shared model of care or be it in a continuity of care model. So what really it matters is the commitment from midwives. And they need to believe on this model of care, and they need to show by working so that they will going to positively influence the policymakers. Unless and otherwise, policy change will not come from the sky. So we need to work on ground. That's the most important thing. The other thing is professional associations, other organizations, non-governmental organizations, or higher education institutions needs to work collaboratively, and they need to work on this, and they need to positively influence policymakers to consider these kinds of model of maternal health care to be considered as one alternative model of care in lower income countries. You know, because whatever the case is, midwives are the frontline healthcare providers, be it in lower income country or be it in higher income countries. So we need to capacitate, we need to create a conducive working environment for midwives to work and to contribute more on the reductions of maternal and neonatal mortality. So for this, midwifery continuity of care might be one very important alternative. If medicalization of obstetrics care becomes more increasing in lower and middle income countries, they may not control its cost. That is the most important thing. So if they exercise continuity of care model from the very beginning, it will really reduces the cost related cost-related burden in their country. That is the most important. Otherwise, whenever there is high number of unnecessary cesarean section, unnecessary medicalization, and other issues, it really has its own negative impact on the cost of the healthcare system. So the lower income countries, the poor pregnant mothers may not have access for this thing. For example, if I tell you the Ethiopian context, the maternal healthcare service is really free. So every pregnant mother are not in a position to pay. So the government will cover that one, but it will not continue as like this throughout for the future. So the government may change the policy, and so every pregnant mother may be asked to pay for their healthcare financing. So during that time, with unnecessary medicalization, do you think that what will happen in the lower and middle income countries? So for this, I believe midwifery continuity of care model might be one alternative solution, because it really encourages normalization. So with this, we were going to increase access to antenatal care, intrapartum, and postnatal care. So midwives really want to learn from this experience. So we need to expand, we need to scale up. So we need to discuss and learn from each and every country on how we're going to scale up, because on its effectiveness, there is no doubt. There is no any question on this. So what is the remaining question is on how we're going to scale up and on how we're going to contextualize for lower and middle income countries. So for this, we need to have collaborative work, experience sharing, and these kinds of webinar and global discussion is really very important, because we will learn from country to country experience. That's what can I say?
I think you're absolutely right. I think there's so much to be learned from each other. And I think you're right. The evidence is clear, but I also still think we need more data, and some of the data that you've collected and the outcomes that you've been able to demonstrate are really powerful. And then that scaling up and the operationalization of it, there's so much that could be learned from how we each have done that in different settings. So yeah, I think there's lots of lessons to take away. Thank you. Megan, what are your thoughts on how midwives, what you've learned today and how it might impact the continuity picture in Ontario? And what are are there challenges that you think are unique or that maybe haven't been touched on in the discussion today?
Yeah, I will keep it brief because I know we have time, but I was going to touch a little bit on the midwifery leadership piece and what happens when you have the capacity in place to be able to provide continuity really effectively. So I know we're talking about scaling it up. How do we, I really think that continuity is this, I think, thing that we're chasing that we really need to honor and really need to be mindful of how we want this to kind of scale over the next sort of few decades, which is why I think we do need more data on on a granular piece, what does continuity look like, and what do the clients feel they need to be able to keep the spontaneous vaginal delivery rate up and the C-section rate down and all of those finer details. But what's interesting in our local center in London is when we talk about capacity building, if you think about continuity, the way I sort of conceptualize it is it's really a healthcare provider or a group of midwives that are taking responsibility for the whole person, and that person's whole course of care or the part that they're responsible for. And then when they're not present, they're ensuring that there is a plan in place for that person that's going to meet the needs as best that they can. So if this is something we know works really well, in our unit, we have a high risk center. So the piece that was missing up until a few years ago was really just a well-established funded midwifery leadership position. And so what's interesting is if you have capacity built into the organization, and I'm talking on a smaller level, not like on a provincial level necessarily, but if you have midwifery leadership, effective leadership, what I've noticed is you do get more collaboration through the art of negotiation and discussion. When midwives are given capacity to make decisions and sit on committees and decision-making committees that are going to be responsible for these outcomes and how things are played out, things I find do go a bit differently. And so what I find is this midwifery leadership position can advocate for the midwives, but also for the clients. So I think having a perfect example would be just a few weeks ago when I had a client who had a pretty sort of complicated birth situation. And traditionally that we would have transferred care to the obstetrician because it was complicated. Now, the obstetrician on call said, you know, how about I just take over periodically and we'll just see what happens with the baby's heart rate because it might normalize, in which case, why don't I give care back to you because you're the person that they want to be really delivering their baby or being with them. And I thought that's a great way to honor continuity. And that's what we did. And it worked beautifully. And so that I really think came from having a midwifery structure in place and a department in place that is involved in the decision making and how things roll out. So I think when we're talking about ministry level capacity, I think we need to take care of the midwives and give them that space to be able to be present and make those decisions, to be able to help preserve the care for the client. That's one thing. And then the other thing is full scope. So I know if you have midwives who do more full scope, meaning they are keeping care for clients that maybe they wouldn't have otherwise before, or their care is maybe a bit more high risk. If you work in full scope in a center where you don't have good midwifery capacity or resources or advocacy, then I find, and I don't have any data on this, but I find that that doesn't go as well because midwives need support and they need to be able to make safe decisions within a network of support. But if you have a center where there is collaboration and you can learn from each other and that space is there, then that full scope actually protects continuity because then the midwife has autonomy over the decision making and can keep care longer in a safe environment. So I think some of the challenges when I keep trying to think about continuity, it really comes down to capacity building for midwifery. And if we're going to build that capacity on a provincial and national level, I think that's where we'll start to see more continuity being preserved in other models in ways that clients would like to see.
Yeah, I think that's a great point. Anything that scales up our autonomy will translate into, improved continuity, improved capacity. And I think, it comes back to even what Solomon was saying too, around the shared philosophy and having that. And you mentioned that too, Megan, the shared philosophy when we're collaborating as well can play a big role in promoting autonomy when our obstetric colleagues are on board with the same philosophy or recognize the value of continuity in improving outcomes. So yeah, lots of really good points here. I think we should turn it over to the audience for their questions because there are already a few in the chat. And maybe I can read them out. And then if there's a panelist who feels like they would like to answer the question, they can jump in and we can have a bit of a conversation. So one person asked about, looking at the model from the UK where they have community and then hospital-based midwifery, if that has a positive impact on clients and providers with respect to continuity. I don't know if anybody feels like they can speak to that, or if you see that as looking again more fragmented, as in that kind of referral system, or if anyone has thoughts they want to share. Or I should have invited a UK midwife to chat about it.
Yeah.
Lisa?
No, yeah, because it's just I had an experience observing the UK model because I was doing my master in the UK back in 2014. And well, I think they have a really strong model, and with not only with the caseload alongside midwifery unit that's been settled for many years, though a couple of the challenges I think they still have it, but I think there are some, but I'm not sure. Maybe I can share it later because yeah, it depends on where the evidence is. Yeah, but the current evidence, I think we can't identify it. Yeah, because yeah, that's simply strong.
Yes. Thank you, Megan.
I was just going to quickly say that although I've never worked in the UK, in Canada, we have something called an alongside midwifery unit, and we have some data, but also some anecdotal evidence from the midwives that when they have a hospitalist midwife who's available to support the community midwives, there are some positive things that come from that in relation to continuity as well, where the clients, sometimes the hospitalist midwife will start the induction or start the care while the known midwife is able to rest for a bit longer and come in when labor is active and then for the delivery. And some information that we have seen from that is that the clients actually like that, and that was part of the design of the alongside midwifery unit, was asking them, would this bother you? And they felt that it was actually more beneficial to have their known midwife for the birth than to have them come in early and then have to go home for sleep right when the baby was going to be delivered. So I know that just anecdotally, there's been some positives that have come out from the hospitalist and the community midwifery in this particular case working together.
Thanks, Megan. Solomon.
Yeah, maybe, yeah. When we consider about midwifery continuity of care medicine, there might be different organization of midwives within the continuity of care. For example, there might be alongside midwifery continuity of care model or a freestanding midwifery unit, and like the UK model, which is the hospitalist plus community midwifery model. So what matters is, does it really fulfill the most important criteria for continuity of care? What we have previously mentioned, the continuity of care provided, continuity of information, and continuity of care of the service that the woman really needs to have. So with this circumstance, we might consider the UK model, that is the community midwifery plus the hospitalist model. But we need to be sure that with the community and the hospitalist midwife, the woman needs to know these healthcare providers ahead, especially during the times of the intrapartum. That's the most important. So continuity of care provider and continuity of care and continuity of information has to be there. Unless and otherwise, we can't say that it is a continuity of care. So other countries might also have a freestanding midwifery within the community. Others might have also alongside midwifery. Within the obstetrics unit, there will be alongside midwifery unit where midwives organize themselves and provide continuity of care. So it might differ from country to country. It's based on how they organize the midwifery continuity of care. But the most important thing is, does it really fulfill the most important criteria for continuity of care? Yeah.
Yeah, and I think you've brought up some good points that, a lot of the literature on continuity looks at not just the relational continuity between the known care provider and the client, but also that continuity of information and the continuity of management. And to come back to your point, Megan, I think in that hospitalist example, it was because there was that consistency of philosophy and consistency of how care was managed. So even if it was a new midwife, it actually helped to promote continuity and also kept the known midwife well rested, who could then come in and attend the birth and was more likely to be there. So kind of a double win there. Yeah, and I think it's interesting. The UK model, I think, lots of people have looked at specifically around continuity, and it's actually under threat in ways in the UK that we hadn't anticipated. And I think, globally, we can see that as well, that continuity, although we have good evidence for the benefits of it, is often the first thing that people think needs to be changed when there's concerns about midwifery outcomes or about the midwifery approach to care. So we need to continue to advocate for continuity and what we think is important about it. Lots of other questions in the chat. Okay, so let me see. Specific questions. One for Solomon: how have other healthcare providers received your research findings in your country? That's a great question.
Yeah, actually, it depends on.
It depends.
Perception. Yeah, it depends on the perception, but as far as the evidence is generated based on most important principles of research protocol, so they will accept that, but the acceptance might be different from person or from temporal care provider. As a midwives really want to see the full scale implementation of that. And we also quantitatively address obstetricians and other healthcare providers working with the maternal child, and we explore their attitude, their knowledge and skill related to responsible care. They really want to see these kinds of things, but it might be different from person to person. So to influence other healthcare providers more and more, we need to generate more evidence, and we need to prepare a policy brief, and we need to bring a change in the policy of the healthcare system. That's the most important. Otherwise, it might be their field. So we need to generate more evidence, more as far as we generate more evidence, so that they will be influenced more everyone. That is what's.
Yeah, so I guess you've discovered your life's work is to keep doing this research, keep sharing the story that you're learning with everyone, help to change that policy landscape. That's amazing. Question specifically for Renata regarding the point about larger midwifery group practices have more transfers and benefit from this. Do you think there is some kind of incentive for this to be happening?
Yes, definitely. Good question. Because in the Netherlands, the payment structure is like that the midwife is paid for each client. So when the client needs to be transferred during birth, then she receives the same amount as she would receive when she was the main care provider during birth. So it doesn't matter if she does or does not transfer the client, she receives the same amount, but she has less work, of course. So even though the woman is not in labor yet and only the membranes are ruptured, and she transfers the woman, then she still receives the same amount. It's a bit the same as I managed earlier about the organizations receiving more funding for the acute care, for the complicated pregnancies and deliveries. It's stimulating, it's creating the focus in the wrong direction, because continuity of care needs more time per client, and time is expensive, time of healthcare professionals. So it's not a good stimulation.
Yes, the business of birth and the business of continuity, the financial aspect is a challenging one for research, right? To be able to tease out, yes, it takes more time, but then what are we saving the healthcare system by having more vaginal deliveries or having improved outcomes, higher rates of breastfeeding, lower rates of preterm birth, all of the other benefits that we see. So the financial side is always a challenging argument to make because it's difficult research to undertake. Okay.
Yes, but the benefits are also, sorry,
no, it's okay.
The benefits are for society and for the healthcare system, and not for the organization or the care provider per se. So the benefits are in a different area than the costs.
Yes, that's a very good point. And that the individual person providing the care doesn't see those benefits necessarily. They see it in a more altruistic societal impact, but not a direct personal impact. It's a really good point. Okay, we have someone from Quebec here in Canada saying that they're finishing their master's degree on the participation of parents' committees in the organization of services, and the difficulties of ensuring continuity of care with two midwives has been identified as an issue. And that's come up in our discussion today. They suggest that by involving more actively in the discussions and organizational issues, and by offering the opportunity for members of parents' committees to give their point of view, so coming back to that service user, patient, client perspective, it seems that the solutions suggested make it possible to take this consideration, the needs of women, but also to raise awareness of organizational issues among clients. Yeah, any other thoughts there on I think the input from clients is a huge part of this. The other piece that we've only touched on a little bit is the input from maybe students and learners, and how we help to build this into their training. So any thoughts that folks want to share on either the client or service user impact or the learner impact, midwifery learners?
I can say something, Beth, about this. I think that's something that we really need to look at, because when we were even just talking about our study design, it always comes back to the question of like, where is the line between, and I just don't think we know that yet. You know, how many midwives is too many? This is one of the conversations in the Q&A, one of the questions. How many midwives is too many? Where do you start to see a compromising of health outcomes based on that? But then it doesn't also address the other phenomenon, which is when you attend somebody and you've never met them, and that particular client or patient really, really appreciates that midwife. You know, they come back and say, I want them again. Like, I met them for the first time in the most vulnerable moment, but there was something about the relational continuity that they built really quickly, that fostered trust and empathy for them to want to come back and see them again. So I think there are things we still need to tease out. And I think that's where you get conflict on midwifery teams, because you have one midwife potentially who does these 3 forms of continuity, or 2 of them really well. And then you've got someone else who perhaps maybe doesn't. And then you get a bit of conflict across providers and from the client. And then you get, you know, this issue where you're trying to argue over like, who's the better midwife, when it's not about that. It's a lot about the approach. So I think that's still to be determined. Maybe, Beth, you've come across more information than that, but that's something that I think, and what's interesting when you talk to students, because another study we were doing was looking at like student watching their preceptors learn how to engage with clients, is they really see objectively the patterns and trends in communication, and they get to see different midwives do it, which is really cool. So their perspective, I think, is really fascinating. And I think incorporating some of their feedback would be really helpful when it comes to understanding how we build that relational continuity.
Yeah, and I think it's so important, if continuity is a priority, to build that into the curriculum and the model in which we train students from the beginning, so that it doesn't become this thing after the fact that they have to now figure out how to organize their life or how to provide care in that way. It needs to be embedded throughout. So I think that's really key. Yeah, and I think the client perspective is going to be a really fascinating piece that for us, we're really excited to keep unpacking, because some of our early insight shows that, you know, how people, or what matters to people, is different depending on, you know, baby number 1 versus baby number 3, or even within different equity seeking groups or different demographic populations, their needs for continuity are different. What matters to them is different. And the way in which we apply continuity is actually different, and that may shape those outcomes. So I think there's more for us to kind of keep exploring in that place. I am going to have to wrap up our discussion. I'm sad to do that, because we've had such a great dialogue. There was a question in the chat as well about the volume of caseload and what's the magic number. And Renata has answered that there is some research looking at caseload volumes, and 40 to 50 seems like a good amount. So that was a question that someone brought up. But I think, again, that's context specific, and probably some more research on that would be really beneficial. But
it says the evidence says that 40 for caseload midwifery, and maximum 360 for a team-based midwifery continuity of care model.
Yeah,
but
that's fantastic.
it is highly dependent on country to country or context specific. Yeah.
Yes.
There is no definite number.
That's fantastic. We'll try to share a few of those resources. When we post the video from this panel discussion today, we can put the citations and people can go and read a little bit further if you're interested in this topic. And I can't thank you enough, our panelists. I think this has been a really engaging and interesting conversation today. And I'm so grateful that you were from various time zones across the world able to join us and to share your perspectives and insight. I think this has been really, really wonderful. This, as I mentioned, is day 2 of our symposium, and we are back here tomorrow. So we have another panel discussion. We'll just put up the poster for that. So tomorrow, this is more of kind of a local perspective, looking at collaboration and how collaborative models are being explored and the impact that they're having in different places across Canada. So join us tomorrow. You can use the same Zoom link you used today, and the symposium runs from 12 until 1:30 Eastern Standard Time. And yeah, we're looking forward to another great discussion tomorrow, and we look forward to seeing you. We have a quick poll we can put up just to get your feedback about the session today. And we're really grateful that you've been able to join us. And remember to fill in the survey you receive after so you can get your certificate of attendance. And join us here tomorrow when we do this all over again. And thanks again, everyone. Have a great day.